Welcome to the Irish Practice Nurses Association online education series for general practice nurses. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA, and today we will be discussing the topic of hemochromatosis. Haemochromatosis is a genetic disorder where an excessive amount of iron is absorbed from the diet, leading to progressive iron loading of parenchymal cells in the liver, pancreas, heart, joints, and other organs. There are two types of hemochromatosis. Primary hemochromatosis, where the condition is inherited and is caused by a mutation to the HFE gene on chromosome 6, and secondary hemochromatosis, where it results from another condition such as chronic liver disease or from treatments such as blood transfusions. Hereditary hemochromatosis is the most common genetic disorder in Caucasians, particularly those of Celtic and North European descent. It is the most common hereditary disorder in Ireland, where its prevalence exceeds that of cystic fibrosis, PKU, and muscular dystrophy combined. The condition affects 1 in 200 people across Europe and 1 in every 83 people in Ireland. 1 in 5 Irish people are carriers of the gene. Based on prevalence and population data, it is estimated between 40,000 and 50,000 Irish people are affected with the condition. However, only 20,000 people are actually diagnosed with the illness. Hemochromatosis is a recessive gene disorder and can only be developed if both parents are carriers of the HFE gene. Several different mutations to this gene have been discovered, but two main mutations, C282Y and H63D, cause hereditary hemochromatosis. The C282Y mutation is associated with most cases of hereditary hemochromatosis. H63D mutation seems to have less impact, as do other rarer types. Carriers have one altered and one normal HFE gene and are generally not affected by iron overload. A small percentage of carriers, however, do have iron overload, which can lead to organ damage, and they should be monitored for symptoms on an ongoing basis. 1 in 700 people with hemochromatosis have no mutation in the HFE gene. This is known as non-HFE hemochromatosis and is due to mutations in other genes. Hematomacrosis symptoms include nausea, weakness, abdominal pain, constipation, and joint pain. Untreated hemochromatosis can lead to liver damage, heart failure, and diabetes. Clinical features are secondary to the buildup of iron in various organs. The buildup is gradual and symptoms do not usually appear until between 30 and 40 years of age. The majority of patients with hereditary hemochromatosis are men aged between 40 and 60 years. Men tend to be affected with the condition more severely than women. Hemochromatosis affects as many women as men. However, as women lose iron through blood loss with menstruation and childbirth, they are generally protected until later in life when they reach the menopause. Iron buildup is caused by the deficient production of hepcidin, an iron regulatory hormone secreted by the liver. This deficiency is due to a defective HFE protein in the liver, which under normal conditions can detect iron levels and signal hepcidin production accordingly. Hereditary hemochromatosis is underdiagnosed because of its late and multiple nonspecific clinical presentations. Untreated, the body deposits extra iron around the heart, pancreas, and liver, which over time leads to serious damage. In its fully developed state, it can be fatal. Premature death may occur secondary to diabetes mellitus, cirrhosis, cardiac failure, and hepatocellular cancer. Alcohol, a diet high in iron, obesity, and hepatitis B and C increase the chances of clinical symptoms. Early detection and treatment, however, prevents organ damage and allows a normal life expectancy. Hereditary hemochromatosis is particularly amenable to diagnosis, treatment, and ongoing follow-up in the primary care setting. A diagnosis of hemochromatosis may be suspected with two or more of the following: type 2 diabetes mellitus, especially those diagnosed at an early age with elevated LFT, hepatomegaly, early onset sexual dysfunction, or abnormal iron markers; unexplained liver disease or liver disease with abnormal iron markers; chronic unexplained fatigue, weakness, and abdominal pain; asymptomatic patients with incidental elevated LFT, ferritin, or hepatomegaly; early onset arthralgia, atypical arthropathy; early onset male impotency, early menopause, and loss of libido in women; early onset arrhythmias and cardiomyopathy; increasing skin pigmentation or permanent tan; first-degree relatives over 18 years of age of a confirmed case of hereditary hemochromatosis; and men aged 40 to 50 years. Both TS and ferritin are required, as patients in the early stages can have normal ferritin but raised TS. To confirm a diagnosis, fasting TS and serum ferritin levels are measured. Non-fasting tests may be carried out initially if considering the diagnosis or as part of a general screen. Ferritin is an acute phase protein which can be raised in intercurrent illnesses. If the TS is greater than 50%, a fasting TS and ferritin is needed, as it avoids effect of diet and diurnal variation. Transferrin saturation levels greater than 45% are strongly suggestive of hereditary hemochromatosis, but do not necessarily indicate a need for treatment unless the ferritin threshold is exceeded. If there has been recent blood loss for any reason, this result may be normal. Ferritin levels greater than 300 Ng per ml for men and postmenopausal women and greater than 200 Ng per ml for premenopausal women are suggestive of minimal iron overload. Moderate iron overload is defined as ferritin greater than or equal to 500 Ng per ml and severe overload as ferritin greater than or equal to 750 Ng per ml. If iron studies are positive, then genetic testing should be performed for C282Y and H6-3D mutations following appropriate counselling and discussion regarding the implication of positive test results. Other investigations carried out include urea and electrolytes, liver function tests, blood sugar, urinalysis, oral glucose tolerance test, HbA1c, lipid profile, ECG, chest X-ray and X-rays of the affected joints, and a liver biopsy may also be required for those who are likely to have significant liver damage and one or more of the following: abnormal transaminases, ferritin greater than 1,000, or alcohol abuse. If liver cirrhosis is present, the patient must be monitored for the development of hepatocellular cancer by liver ultrasound and estimation of serum alpha-fetoprotein levels 6-monthly. First-degree relatives of individuals diagnosed with hereditary hemochromatosis should be screened. Consideration should also be given to second-generation relatives. EASL recommends that children are not screened until they reach an age where they understand the implications of the test, can give informed consent, and take responsibility for the results. Consideration should be given to screening the diagnosed individual's partner, as this would have implications for the screening of children if both parents are carriers of the hereditary hemochromatosis gene. Screening should include fasting iron studies and genotyping. Possible consequences of genetic testing in relation to life insurance should also be explained. Treatment by venesection is commenced when there is evidence of iron overload and 400 to 500 ml of blood is removed on each occasion. When serum ferritin is greater than normal, venesection is performed twice weekly to twice monthly until ferritin is between 25 to 50 Ng per ml. This can take up to 18 months. When normal levels are reached, venesection is tailored to individual requirements. Serum ferritin levels of 50 to 100 Ng per ml and transferritin saturation of less than 50% can be maintained by about 4 venesections per year. A strict iron-deficient diet is not recommended, but iron-rich or iron-fortified processed foods should be avoided or eaten in moderation. Iron and vitamin C supplements should be avoided. Drinking too much alcohol, especially with meals, should be avoided, as this can increase iron absorption and cause liver disease. Alcohol has been shown to suppress hepcidin production, leading to a further increase in iron absorption and progression of the disease. Tea and dairy products with a meal are recommended to reduce the amount of iron absorbed. For pregnant women with hemochromatosis, early referral to a specialist obstetric hematology service is recommended. Serum ferritin should be monitored throughout the pregnancy. Iron supplementation should not be given to pregnant women with hereditary hemochromatosis. If high, therapeutic venesection is generally deferred until the end of the pregnancy. A full-term single pregnancy generally removes approximately 1 gram of iron from the mother. Many hereditary hemochromatosis patients can now become blood donors. The Irish Blood Transfusion Service aims to collect 12,000 donations annually from hereditary hemochromatosis donors, which is approximately 10% of the national blood supply. For many patients, this means they can now attend blood donation clinics closer to home and at a more convenient time. This will also help release daycare beds and resources for other healthcare service treatments. However, donors must meet specific hemochromatosis management criteria. There is no maximum age limit for HH patients to become donors. However, if age 70 and above, a doctor's letter or GP certificate will be required. Individuals with HH who do not and have never required venesection can give blood. Some restrictions apply to blood donation during COVID-19, and for more details you can visit the giveblood.ie website. To donate blood, an individual with hereditary hemochromatosis must have completed iron depletion therapy with at least one therapeutic venesection without complication and be in the maintenance phase defined by the Irish Blood Transfusion Service as requiring no more than 8 venesections per year. They can only attend an Irish Blood Transfusion Service clinic up to 4 times a year with 90 days between venesections. They must not have had a venesection in the 2 weeks prior to the blood donation and must not have a serious complication of hereditary hemochromatosis such as liver cirrhosis, cardiomyopathy, cardiarrhythmias, or insulin-dependent diabetes mellitus. The Irish Haemochromatosis Association is a registered charity which provides support and information for patients and their families with hemochromatosis and related disorders. The association raises awareness of hemochromatosis both in the medical and general population, facilitates networking among members, and encourages screening of members' extended families. They can be contacted on phone number 01 8735911 and their email address is info@hemochromatosis/ir.com. So let's now consider the role of the practice nurse. Practice nurses play an essential part in the delivery of quality primary care and have a growing responsibility in the screening, assessment, treatment and management of many long-term conditions. We provide ongoing support and education. Key roles are to establish a therapeutic relationship with the patient, assessing their understanding of the condition, establish goals and expectations for successful management of their condition, and evaluate the physical, emotional, and psychological effects of the condition on the patient's well-being. We are communicators, we provide advocacy, and we provide counselling. Assessment, monitoring, audit, and evaluation for progression and effects of the therapeutic regime on a patient with hemochromatosis is a continuous process. The scope of practice nursing has evolved and continues to evolve. Many nurses can now order tests and perform diagnostic examinations either independently or in conjunction with a doctor. Practice nurses are leading the way in quality improvement initiatives and research, and practice nurses play a pivotal role in managing the illness and improving the patient's quality of life by implementing person-centered care, monitoring and evaluation of symptoms, outcomes, and responses to therapy. This is a list of the references that were used in the production of this presentation. I hope you have enjoyed this presentation on hemochromatosis, which is part of an online educational series for general practice nurses produced by the Irish Practice Nurses Association. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA. Thank you very much for listening and watching.